Okay, we're going to move on to another minimally invasive glaucoma surgery. This one called the Hydrus Shunt. I have done some consulting for Ivantis, so you should take that into account. So this is a 8mm nickel titanium trabecular meshwork stent. And so the goal of this procedure is to dilate Schlemm's canal. It dilates it almost to a supernormal cross-sectional area, to about 4 to 5 times its natural area. It's not a tube as per se, so it actually doesn't have a lumen inside of it. Its goal is really to dilate the canal and not necessarily form a new tube to kind of drain things into the canal. And the way it's designed is to really kind of hug the anterior section of the trabecular meshwork as opposed to kind of pushing against the back end where it might be a resistor to the collector channels. So this is the histology of what it looks like when it's in place. So it's so you can see over here it's meant to hug the anterior side, and it kind of has a dilation aspect. So much like canaloplasty, where you're actually pulling the canal open. This is what this procedure is meant to do. So this is kind of some of the practicalities of how I would do it. I think it really is a fairly straightforward procedure. It's not extremely complicated. You can either do it before or after phacoemulsification. If you go through the corporate training, they actually recommend doing it after phacoemulsification. I like doing it before phacoemulsification. I think you have better anterior chamber stability. Sometimes with gonioscopy, even if you have very minor changes to the cornea, either because you haven't taken care of the ocular surface properly, or because you've caused endothelial changes as a result of maybe phacoemulsification of a dense lens, you can really impair your view. And so it doesn't take, and you see this a lot in pediatrics, for those of you who do pediatrics as well, pediatric goniotomies. If there's even just the slightest clouding of the cornea, it can really make the view quite difficult to complete the procedure. There are some theoretical advantages for doing it after, and I've done this a couple of times. So if you have a narrow angle, but still one that's open, you can consider doing it after the phacoemulsification. I've not found this to be an issue, and I think for people over here where we have such a room full of, I'm sure, great phacoemulsification surgeons, it's probably not that much of an issue. The eye does become soft, so you want to keep that in mind as you're making your keratome incision. So it's probably prone to becoming a longer than normal incision. You can get some heme also at the location of insertion, and I think maybe in about 5 to 10% of cases, the heme can kind of come over into the area where you're making your capsulorhexis. I've not found it to be problematic, but it can make it a little bit more challenging. So especially if you're teaching maybe early cataract surgeons to do this, may not be the ideal procedure. So I think most of the surgical steps, I think people have gone over this already. The initial surgical steps are really designed to optimize the view and properly position the insertion device. I think my goal originally is to sit temporal and then have a scope that's tilted maybe 45 degrees towards the eye. I do that just so I'm already kind of close to where I'm starting with the Hydrus Shunt, and so I tilt it about 45 degrees, which is maybe less than the 7 degrees that was mentioned earlier as the ideal total tilt between the head turning away from you and the microscope tilting. I think this 45 degrees allows you to maybe have a good enough view where you can do your paracentesis, where you can inject your lidocaine, your epinephrine, and your viscoelastic. And that way, when you get started, you're already ready to do it. And then there's just a little bit of additional tilting of the scope and a little bit of additional tilting of the head to maybe you get that extra 25 degrees to get a total of 70 degrees of angle. You put viscoelastic on the cornea, and then you further tilt the scope and rotate the eye away from the surgeon. And I use a direct gonioprism, which has been discussed before as part of the GAT and the dual blade as well. So this is kind of just the simple schematic. If this is a left eye, then you're going to have a superior incision just underneath the upper eyelid, and you're going to I make an incision which would be convenient for a superior phacosurgeon, where you make a supero. It's almost at 12 o'clock, just maybe at 1 o'clock. I like to kind of position the inserter so that I see that it ends up flush on the top of the cornea. So that way I know when I put it in the eye, it's going to be sitting in the right spot, and so it's very easy to engage the trabecular meshwork. If you have it so that it's maybe kind of angled in too much, then sometimes it's harder to insert it, or if you're inserting it so it's kind of tilted away, you're going to have a harder time inserting it into the trabecular meshwork. This is the inserter itself. So it has 3 parts. So it has the actual insertion device, so a very small tube through which the stent comes out. It has a little cannula which rotates that actual cannula. So obviously you don't want it pointing down towards the iris, or you don't want it pointing up towards the cornea. You want it pointing in the iris plane. And then you have the tracking wheel, which both, if you push it out, it actually pushes the stent out, and if you pull it back, it pulls the stent back into it. So I think the goal is this is a post-operative photo from one of the published articles. What you want to see is 3 windows visible in the trabecular meshwork. So you can see the windows right here, and right here. Let's see if this works. Yeah. So you can see those windows in each of those areas. And then you want to see a small, they say about a 1 millimeter portion of the inlet in the anterior chamber. So these are kind of like the steps that I'm showing you as part of an operation itself. So I like to kind of first, before I've done anything, just lay it on top of the cornea and see where it's going to go. And so this is the angle that I'm going to take when I have the instrument inside the eye itself. And so here I'm laying it on top, and so I'm illustrating. So this tells me where I want to make my paracentesis, and also the direction of the paracentesis. So this is fairly superior, but I might make it in that area. You're going to go ahead and make your paracentesis at that point in time, so I probably didn't go quite as superior as I'd want. Sometimes, especially in a left eye, the upper lid can get in the way, and so sometimes you'll want to actually use a forceps and pull the eye inferiorly as well, so you can really kind of get a more superior access point for your paracentesis. You'll want to fill the eye with epinephrine and lidocaine and viscoelastic, which I'm finishing up over here. Then you want to put viscoelastic on the cornea. Probably anything that you would use to fill the anterior chamber is adequate, just to give you a coupling agent to put your gonioprism down on. And then you're going to first want to tilt the head a little bit and tilt the scope a little bit extra. If you don't, you tend not to get this kind of view. I think Dr. Grover was mentioning earlier that positioning is really everything. I think what you'll end up seeing is you won't really see the trabecular meshwork and fossa. You'll kind of see it at an angle, so it'll almost be obscured by the cornea. So when you really have that proper tilt, then you'll start seeing the trabecular meshwork completely in fossa. So maybe we didn't Trendelenburg or reverse Trendelenburg this patient, so you're getting a little bit of a reflux of blood into the canal of Schlemm. I find that to be, if anything, a little bit of a helpful sign. I don't think it really causes additional bleeding in the anterior chamber. So especially when you're starting out, sometimes this can actually be a benefit to you, or a sign that makes things easier. You know, I think with all of these techniques, it's really important, especially if you're primarily a corneal surgeon, is to really get comfortable doing gonioscopy. You know, I think even when we're teaching some of our fellows these, you get a little bit surprised that sometimes they start putting the probe in areas where maybe it's not really where the trabecular meshwork is. And so I think it really speaks to the importance of doing a lot of gonioscopy. You really want to be very confident that what you're looking at is the trabecular meshwork, and not a pigmented Schwalbe's line, or not a ciliary body. And I think all of us have had the experience, especially in America, of seeing a lot of eye stents that were put in the wrong place. And so I think we see a lot of phaco surgeons who are starting to take on some of these procedures, but don't actually know what the trabecular meshwork looks like. And so they have a lot of trouble actually inserting into the right spot. So this is the next step. So you want to kind of bring your inserter right up against the trabecular meshwork. And you can prime it at this point in time, so just make sure that you have that the device is working properly. You can do this outside of the eye as well. And so you want to make sure that so it's primed, so it's just ready to come out, so you can take it out and then pull it back in. I think that then usually it's when you want to engage the trabecular meshwork, you often will see the eye kind of rotate a little bit. So I think it was mentioned earlier that you can tilt the gonioprism some, but sometimes you will see the view kind of come out of place. And you want to actually see the tip of your inserter, just to start losing that metallic shine, so that metallic sheen. So as it enters the trabecular meshwork in the tip, you start losing that metallic sheen. Afterwards, then you simply thread it through, and it can be a little bit hard to tell, especially if you have a very heavily pigmented angle, or if you have a little bit of blood in Schlemm's canal. It can be hard to tell. You can tell a little bit over here that you can see one window over there, but sometimes a second or third window. You really have to either use a different gonioprism or change the angle of the scope if you really want to confirm that all 3 windows are in the proper orientation. Afterwards, you're going to have a small segment that's left, and then if you want, I tend to use a Kugelin hook to push it into place. So I think, with all these surgeries, I think a lot of the videos that have been shown were the really good videos, the ideal videos, but I often feel that that doesn't get people a comfort level. So really what you want to be able to do is to handle the worst cases that you saw. So you'll see that I actually videoed some of my earliest cases, so to be able to show you some of the most difficult cases that I've had and ones that I struggled with the most. And I thought that'd probably be more illustrative than actually showing my best cases, which are probably 90% of them, which actually went very, very smoothly, and there's not really much to be learned from those because everything went very smoothly. So this is one where, so this is a case where I was kind of struggling to engage the trabecular meshwork, and sometimes you do see that you have trouble. And here you're actually seeing that you're getting a very, very bright metallic sheen. And so when you see that kind of brightness, you should actually see it when it's going into the canal of Schlemm. You'll have a much more dulled appearance to the stent, and so it shouldn't be that bright. So I'm trying to re-engage the meshwork, and that's what you're seeing over here is also that there's a lot of small iris processes that are kind of coming up over there. And so because of those iris processes, I'm having a hard time judging exactly like where my entry point should be. So I'm trying to re-engage the trabecular meshwork over here. I feel like I'm losing the sheen, but I might be losing the sheen just simply because there's some processes that are coming up in front. And over here and so as I'm deploying, again, you're going to see that it kind of comes out in between the meshwork and the processes. And so I'm not actually getting it into the meshwork. I'm just getting it to kind of go in front of the processes, in between the processes and the canal. So I think with further dissection, I'm still trying to get the same thing. And I think it's only when I finally come further inferior and try and find a new entry point. That now you can see that there's a much more dulled appearance as it's coming out, and you can compare the appearance within the canal of Schlemm to the appearance outside, and then you can see that it went in much more smoothly. So I think this is a good case to say that if it's in the wrong spot, how do you handle it, and how do you deal with it, and how do you recognize that it's in the wrong spot? So really, you want to see that blunting of that metallic sheen, and then I'm pushing it in a little bit with the end of a Kublin hook, which I find to be much better than a Sinski or something else, where it's very hard to engage the tube. I think when you do start pushing it in, you realize that the entire eye will move with it as well. So that is one challenge as you're trying to push it in, but it's hard to kind of get that proper counter traction, although it did go in some over there. So this is it's the same one. So this is a separate case where here again you get very good visualization. So this looks like it's going to be a very simple case. I have the instrument injected, and as you can see that it just went, it kind of like dove down. So you can see as I advance the stent, it suddenly kind of dives down. And I actually was showing this to one of our corneal surgeons at the time, and he said, "Oh, like that's in a great spot." And I said, "No, this is divin down." So you can see over here it is originally in the meshwork and kind of starts diving down, where you can see it over the scleral spur, and then eventually you start losing it like deep to the scleral spur. And so you have to recognize that this is what's happening, and so I'm pulling it back out. And so it looks like it's in the right spot originally, but then as I advance it, it starts going across the spur, and then even deep to the spur. I think here I did actually make this, so when I have our fellows doing some of these cases, I always tell them, whatever you do, if you're not sure you're in the right spot, don't release the device, because while you can re-grab the final bit and take it back in, it's actually much harder to do than deploying the device. It's much harder to re-grab it, usually because it doesn't sit exactly in the plane of the iris. It's tilted up or it's tilted down a little bit, so it's much harder to re-grab it. And so here I did not follow my own advice. I did actually deploy it completely, even though I was seeing here that it was not in the right spot. I think I was thinking, well, maybe if I get at least one or two of these windows within there. But then once I'm seeing it, I think maybe I have at best one window, which is in the trabecular meshwork. And so you can see it crossing down deep to the meshwork over here and going in. So then I decide that I want to pull it out. And that's much more of a struggle than putting it in. So here you can see very nicely that it's driven down deep. And so at best I have one window in the meshwork. And so what you want to do here is you want to go back and you it kind of essentially the inserter flays open, and you want to grab the tip, although it can be rather difficult. And so I'm grabbing that final inlet. And so the key always is, like I said earlier, don't deploy unless you're really sure that you're in the right position. This is much harder than it needs to be. And I do eventually manage to grab it in the right sense. So you can see that it's kind of not exactly plane parallel to the iris. It's tilting downwards a little bit. And so you can bring it back out and readjust the angle of it. But as it starts coming out also, it does create a little bit of a goniotomy. And so I'm having some bleeding over there now too. So I was able to then bypass this. There probably is a discontinuity in Schlemm's canal, right where I was having that difficulty. And so then I moved the scope more superior and then aim more for the inferior angle. And then you can't see very much of it over here, but then it actually inserts very well into the meshwork after I bypassed that area of what may have been a discontinuity. And then I advanced it forwards. So I've done about 30 cases together. All of them were combined cases. The maximum follow-up was about 4 months. I actually haven't had anybody who I've had to reoperate on. Probably the worst complication that I've had was one person who had a post-op day 1 pressure of 40, although that's come down since then, back on medications. I think the results have generally been we haven't formally looked at them, but I think they've been in line with the published Horizon findings. And so in their Horizon study, they found that the percentage of eyes with a 20% decrease in washout diurnal IOP, so this is what our FDA requires of a lot of devices, that they do a washout and then measure the pressure. And again, at a year and 2 years, they have them wash out all their medications and recheck the pressure. So you're isolating the effect of just the device. So you remove the influence of medications. And so they found that 86% of the Hydrus cases had a 20% decrease in washout diurnal IOP as compared to 70%, which were phaco alone. And then this difference persisted at 2 years as well. If you want to look at the percentage of eyes that were medication-free, it's also a very high percentage. About 80% of eyes were medication-free in a phaco-only group. As Devinder mentioned earlier as well, you have to look at which eyes you're talking about. So a lot of these eyes are eyes that weren't very advanced in the first place. So these are early glaucoma eyes with an average MD of minus 3.6 decibels. The average pressure was 18, and 80% weren't on a lot of medicines, 1 to 2 medicines. So in phakic eyes, there is some data. It suggests that maybe that it works a little bit better than the iStent inject. The pressure ends up around 18 on about 1 medication as opposed to about 2 medications for the iStent inject. You should notice that it's maybe not a lot better than things that you can do in the clinic. So it's going to be interesting to see what the role of this is in phakic eyes, because this is a study done by Antonio Fay, who will be joining our faculty in about a year, who actually showed that there was really no difference in IOP and maybe a little bit less medication than SLT, but of course if you give somebody a choice between SLT and a procedure in the operating room, they're going to go for the SLT every time. So this is, I'm going to end with an illustrative case. So this is a 75-year-old male who had moderate glaucoma in the left eye, borderline IOP control, cataract, and astigmatism. So he was 20/20 in the right eye. He was actually 20/25 in the left eye, but he has 3 diopters of astigmatism in the right, 4 diopters in the left. His pressure was 10 in the right, 15 in the left, and he was on 3 medicines, however. He did have a cataract that was starting to affect him, and he had more cupping in the left than the right, and he had an inferior defect in the left eye, but no clear progression. So, I was thinking about doing a trabeculectomy in him, but then of course you can't really do a toric lens, or it may not be that accurate in terms of how much astigmatism you're going to create. And so we elected for a toric IOL with the Hydrus, and the day after surgery, or the week after surgery, he was 20/20 uncorrected, and he had a pressure of 20. A month afterwards, his pressure was 17, but he was on latanoprost. So the patient was extremely happy. I mean, and it would have been a grand success if his IOP had a higher target. So his IOP was not able to reach these low targets unless we put him on additional medications. And so he might be at some risk of glaucoma worsening, and the question is, you know, how do you balance that against his happiness that he's now glasses free and that you've completely corrected his astigmatism? So I think much of the benefit we've derived is really from the tramp avoidance, maybe more than the Hydrus itself. But at the same time, the patient's very happy, and we're going to give him several years where he can be glasses free. But at the same time, there may be a cost in terms of what happens to his glaucoma, and maybe not as much benefit in terms of being medication free as we'd like.